All right, well, welcome to Adult 1 and Fluids and Volume States. So one of the most important things you need to know for this class is be able to recognize the two best dogs on the planet. You can see here pictures of Gypsy and Gabby. These are my fur babies. I do have children, but you won't hear me talk about them much. All right, so I'm not going to read the lesson outcomes to you. You can review these. Mainly the thing is you need to know how to understand where fluid goes in the body, how it gets there, and how do we manage that. So this is kind of these object outcomes and how to apply that information. So let's start with what you've learned so far. So up to this point, you've learned how to do a physical assessment. You've also learned how to take vital signs and the significance of vital signs. So, prior to this time, you might have been doing accounting, or you might have been packing fruit somewhere and may not have had any idea what an SpO2 was, but now you have some context for what the significance of that is. So, heart rate, respirations, blood pressure, those are essential items in vital signs. And then you've also learned about orthostatic blood pressures. We're going to talk about what the significance of what these numbers mean and how they relate and connect to and are impacted by fluid volume status. And then assessment is a key portion of that. Mentation, capillary refill, urine output, level of consciousness, how patients feel when they're immobilizing, if they're able to ambulate or not, how they tolerate that. All of those are important elements. Sorry for those pop-ups. And we'll pull this all together, and it is definitely has a connection to fluids and volume states. When you do an assessment, what you're getting at is we've taught you how to look at their skin, their color, temperature, turgor, moisture, whether it's intact or not, how it's healing, mucous membranes, how they're mentating, their level of consciousness, are they oriented, how their lungs sound, what their hand veins, neck veins look like, and peripheral edema and blood pressure. All those things we've taught you to assess and look at so far. What we've also said, and you remember from your rubric, there are things there that you say when you do your assessment that you notice are not here. That's because we want you to start thinking about the things you're going to see, because those changes, those alterations in assessment tell you something. And it all comes together to tell you something about cardiac output. You may not have thought about cardiac output, but that's what the heart does to meet the metabolic demands of this organism. And it depends on the context of that organism. It depends on the age, the size, the body composition, the overall health and wellness of that individual, and the presence of any kind of medical or physical insult. So cardiac output is what we're really assessing among a lot of other things, but it's the one thing we're really assessing when we're looking at these aspects of the physical assessment. So what is cardiac output? Cardiac output is basically heart rate times stroke volume. Every time your heart beats, there's a certain volume that's ejected from the ventricle that's measured in milliliters. If you do that over a period of a minute, it's going to accumulate to be a liter over a minute, or measured in liters. Generally 4 to 8 liters per minute. That's a normal cardiac output. That varies a little based on the person's condition, their health, and their body habitus and composition. So heart rate is just what it sounds like. You've been measuring heart rate. We probably haven't talked about stroke volume much. But stroke volume is that volume that's in the left ventricle. Notice I said volume. It's the volume that's in the left ventricle when the heart contracts. So you're going to see that there are 3 components that come together to determine what makes a cardiac output and a sufficient blood pressure. We've taught you how to measure blood pressure. Blood pressure is an indicator of cardiac output, but it is not a definitive measure of cardiac output. You're going to learn more about that in Adult 3. But in order to have a stroke volume, you've got to have a volume. Another, and that may sound pedantic, but you have to have a volume going into the ventricle in order for there to be an output, in order for the organs to get what they need, the necessary nutrients, oxygen, carbon dioxide, potassium, phosphorus, calcium, sodium, all of those components have to have a transport, and they move through the blood. They have to have that volume in order to mobilize those components in their various capacities through the bloodstream. So you have to have a volume. That's preload. That's the volume coming into the heart. The heart has to be strong enough, that's contractility, the squeeze of those two heart muscles, the right ventricle and left ventricle. And then the last thing is the resistance. So this is the force that's exerted back against the heart when the heart's trying to squeeze. And there are times when that resistance drops, and there are times when it increases. And we'll talk about some scenarios where that plays out. Now, when you think about this cardiac output, this 4 to 8 liters per minute, it's a volume. And I want you to start appreciating how that volume gets distributed, because your body is going to prioritize that cardiac output based on the functioning of those organs, based on demand. For example, the body knows that the brain is the essential component of who we are, our identity, our personality, whatever you like to think of that. And the brain off the top gets 15% of cardiac output. So that means that the remainder is going to be divided among the other organs. Now the heart, you may say, well, the heart needs a lot of that cardiac output. Yes, it's prioritized in distribution to it, but its overall percentage is smaller simply because the vasculature around the heart is relatively small compared to, you think of the surface area of the vascularity around the brain and the rest of the body. So heart, brain, and kidneys are going to get the top cut because your body knows we've got to have those to survive. If your body becomes challenged, then it's going to start stealing blood flow from the gut, skin, muscles, and other organs. So I want you to see here a couple of things. The heart and brain get about 20%. The gut gets about 25 to 27%. And with normal functioning, it's going to make sense why that's important here in just a moment. The kidney is going to get another 22-ish% because it has an important role, along with the gut, in fluid management. If you can start to get this in your head, gut is fluid in, kidneys fluid out. Yes, we give fluids, but when you think about normal functioning, you getting through the day, your gut is where you get fluid into your body, and your kidney is what helps maintain the balance, along with some other organ systems as well. Muscles get about 15 to 18% in the skin, anywhere 5 to 8%. So these top four are the ones I really want you to kind of lock down in your memory. Now, let's talk numbers. When you consume fluid in a day, most of us consume somewhere between 2 to 3 liters a day, unless you're one of these people that, carries a gallon jug to the gym and that sort of thing and tries to drink 4 or 5 liters of fluid a day, 6 maybe. So average consumption is going to be somewhere between 2 to 3,000 mils a day, 2 to 3 liters. Now, you think about where you consume your fluids, you consume those through the gut. So all of that, pretty much all of the liquid that you consume is going to go into your gut. And about 2,250 of that is going to be reabsorbed. So we're going to process some of that, and we may lose some to insensible losses or something. But overall, we're going to end up consuming reabsorbing almost all that fluid in the bowel. Your gut needs that liquid to mobilize nutrients through the gastrointestinal tract so that the body has time, this is important, has time to absorb at various stages the various nutrients, electrolytes, vitamins, minerals, carbohydrates, fats, and proteins that it needs in order for us to function. So GI in. And majority of that 2.25 liters is going to be reabsorbed in the early part of the large intestine. That's the ileum. As far as output goes, notice the output on a typical day, your output is pretty much going to match your input unless you've got some kind of pathology going on. Right now, we're beginning to introduce these concepts with normal biologic function. So as long as you've got normal functioning, you're going to put out about as much as you put in. That's maintaining balance. That's euvolemia. You're going to hear that word come back again. Kidneys are primarily responsible for eliminating the excess, or eliminating a majority of what we need to eliminate based on what we've consumed before. So you can see that here. The kidneys are the heavy lifters. About 1,500 mils a day, of this 2,500, they're going to be clearing. What I want you to remember is that the lungs and the skin and feces also carry a liquid component as well. You don't think about fecal matter being liquid until you're having diarrhea. We're going to talk about that effect in just a moment. But fecal material has some liquid in it so that it is malleable enough to be easily passed. The skin also is responsible for evaporation and losing some moisture through the skin. Even when you're not sweating, we still lose moisture through the skin. And then the lungs, just the process of inhalation and exhalation, we lose some about 300 mils there in a day. All in all, we end up with a balance. What the takeaway is, don't worry about the numbers. What the takeaway is GI in, kidneys out. Also, lungs, skin, and feces eliminate fluid. So it's not just kidneys. That's the takeaway. And these things normally balance each other out. All right. So let's talk about the GI tract for a minute. You'll remember from your anatomy that the GI tract has a thick mucosal layer that is highly folded, and in some areas, particularly in the small intestine, there are a lot of villi. There's two reasons for that structure being shaped and function in the way it does. And that is that the folding helps move the material, the ingested material, helps move the ingested material through the gastrointestinal tract for it to be metabolized, broken down, and ultimately absorbed. This highly folded area and this viliated area provide a larger surface area so that there's more exposure to the mucosal layer in order for the essential nutrients to be absorbed. So you have more optimal absorption because you've got more surface area. So we've got time, lots of surface area, and the emulsification and liquefaction of what we consume allows those nutrients to wrap around and sink into all these folds and optimize that surface area for absorption. And what are we absorbing? Well, here I've got it listed for you, all the things. Yeah, we think about our cheeseburger that we ate, or our French fries, or our pasta salad, or whatever it might be. However, these are the nutrients we care about, along with fats, carbohydrates, and proteins, because these are the essential elements that keep us functional, as you're going to see when we get into electrolytes next. So what can you think of that might affect fluid volume status? Things you've seen, encountered in life, whether you've been a healthcare professional or not. Well, think about celiac disease or sprue. These conditions are sensitivities to certain types of food that can actually cause people to have diarrhea and not process those foods well. So if they're not processing those foods well, they're not getting the nutrients out of them. If it's causing diarrhea, then stuff is spending less time in the gastrointestinal tract. It's important because it's got to have time, that emulsified nutrients got to have time around those mucosal layers to absorb. So other conditions such as Crohn's disease, irritable bowel, inflammatory bowel, ulcerative colitis, these not only cause things like diarrhea and liquid stools. So bear that in mind. Remember, any type of diarrhea is more liquid than we're used to our feces being. That means there's more fluid going out. Conditions like Crohn's, irritable bowel, inflammatory bowel, and ulcerative colitis also change the composure of the intestinal lining. It changes the composition and the status, the function of that mucosal layer, which impedes its capacity to absorb nutrients. So other conditions such as Hirschsprung's, biliary atresia, malrotation, Gilbert's disease, Dubin-Johnson syndrome, Krigler-Narr, bowel resection, colectomy, colostomy, ileostomy, diarrhea, all these conditions affect and impact the way the bowel functions, which impacts the fluid that actually makes it into the tissues of our body. Now, bowel resection, colostomy, colectomy, and ileostomy, anything in that class has a different effect because it decreases the time in the gut because you've decreased the amount of gut surface area, and that you can't fix by decreasing inflammation or getting rid of an infection. So bearing in mind that those are permanent alterations, so we have to really watch fluid volume status in those people, particularly early on in those diseases, so until they've adapted their dietary habits to accommodate. Now, what is the takeaway from all of that? Here it is. It's right here. 4 points. If it's going in, measure it. If it's coming out, measure it. If you put a tube in it and you're putting stuff in that tube or taking stuff out of that tube, measure it. If it's got a hole and we put a bag on it and there's stuff coming out of it, measure it. So essentially, if it's going into the patient or coming out of the patient, you measure it. That's a principle to maintain for the rest of your nursing career, regardless of the situation. Now, there will be times when it's not so necessary to measure I's and O's. If a patient's going to be discharging in 2 hours, 3 hours, okay, it's time to transition. But in general, as we're caring for patients, as you guys start thinking about putting in NG tubes, putting in Foleys, if we're putting these things in, these devices in the human body, we need to be making sure we're diligent about how much we're putting into it and how much is coming out. So we have talked about cardiac output, and we've talked about fluid conceptually as it passes through the body. Let's get a little more tactile. Let's get a little more tangible in how we talk about fluid. So the fluid distribution in the body roughly looks like this. About 40% of it is intracellular. About 20% of it is extracellular. Then there's another 12% that is in structures of the body that are hard to really quantify, such as the ventricles of the brain and the cerebral spinal column. And then you have plasma. And now I know this doesn't account for it doesn't add all the way up to 100, but this gives you approximate volumes, and I don't want to get into minutia. Because what I really want you to focus in on is I want you to notice this. First of all, majority of the fluid in the body is intracellular. That may not be what you expect, because the intracellular space, when you first think about it, sounds small. However, there are so many cells in the human body that we have small amounts of fluid packed all over the place very compactly. So majority of the fluid is intracellular. So that means that we need more in there, and it can shift out of there. And extracellular fluid is the fluid that is in the spaces between the intracellular fluid and the plasma. And I'm going to show you a slide in the next presentation about extracellular and intracellular fluid. So don't worry about that right now. What I really want to delve into is this plasma, this 5 to 6% of the fluid that's in the body. This 5 to 6% of the fluid that's in the body, this is what the heart is pumping around. This is the substance of cardiac output, if you will. Now, the numbers below that speak to, I know they don't match with the whole distribution of fluid. Well, they shouldn't, because those numbers reflect the distribution of this 5 to 6% of plasma. Plasma is the liquid that is circulating in the body with each contraction of the heart and with passive movement of the fluid by walking, ambulating, and using your muscles. What I want you to notice here is that 70% of that plasma is in the venous compartment, the veins and venules. We're going to talk about where it sits and all in just a minute. And there's some good reasons for that. About 10% of that overall plasma is sitting in the arteries or arterioles. Then you've got another 10% that's around the pulmonary vasculature. There's a lot of surface area around the pulmonary vasculature, so there's a lot of lung surface area there. And then you've got about 5% in capillaries and another 5% in the heart. So when you think about that distribution between the veins and arteries and remind yourself of the anatomy, it begins to make sense. If you remember that the arteries have a thicker wall, they have a thicker lumen and more muscular lumen, a thicker muscular layer around the structure, which means it's tighter and it creates a pressure or resistance. This combined with the squeeze of the heart creates a pressure that we measure and refer to as blood pressure. That's the resistance. It's what the heart has to push against to get that fluid out to with the necessary nutrients out to the tissues. The venules and veins, that's a low pressure side. So if you have gravity affecting a low pressure tube, then that low pressure tube is going to have a greater capacity for stretch, much like a water balloon is bigger at the bottom. It's going to have a greater capacity for stretch, and it's going to hold more of the liquid. So arteries hold less of the liquid, and venules and veins hold more. There's a benefit to that for us, and you've experienced this anytime you've stood up too quickly. If you're sitting in a chair and you stand up too quickly and you get lightheaded, that is your body experiencing a shift in cardiac output matching metabolic need. Your body goes, whoa, if I better sit down or I better stop or whatever. What also happens immediately, there are certain structures that sense those changes and respond by constricting the venous side, which immediately moves. If you look at the blue distribution here, it immediately moves blood, extra blood, into the central circulation, which is why you don't necessarily pass out just because you stood up too fast. So I want you to think about these things right here. Focus on that. And then I'm going to ask you a question in a minute about blood pressure and how it's related to that. These images are intended to paint a picture for you about what I just said. Don't worry about all the initials. What I want you to see is the gray and the red. If you look at the standing picture, you can easily see that when an individual is standing, you've heard people talk about, I have pooling in my feet. This is a simple illustration of how gravity affects the distribution of liquid in our lower extremities every day. This is as a result of the planet sucking us onto it. So this is normal, and the body compensates for that. You can also see how lying down causes that volume to shift in closer proximity to the heart and the central circulation, which can, for a lot of people, create a better blood pressure. This picture helps you understand how we can recruit that volume back into central circulation and create an increase in cardiac output. It can also illustrate the opposite, and that is if a person is supine and we sit them up, you can see how when that fluid shifts by gravity into their hips, waist, and pelvis, that their blood pressure may decrease a little bit. And then when we stand them up and it shifts to their feet, it could cause orthostatic hypotension. That's why we take those orthostatic pressures to see if the patient's accommodated this. So this slide right here kind of gives you an overview of where we're really going with all of these fluid and volume states. There's obviously optimal. This is what you've heard me refer earlier to as euvolemia. That's the optimal piece. Now there's also hypovolemic state and hypervolemic state. And as the hypovolemia increases, the conditions get worse in severity. And as the hypervolemia increases, the conditions get worse in severity. You can see here the conditions that tend to present with these two conditions. Arrhythmias like tachycardia, low cardiac outputs because there's low volume going in, hypoperfusion, infection, organ failure, etc. I'm not going to read this all to you because I want you to study this and be familiar. And then with hypervolemic states, these are the fluid overload states. The symptoms, the manifestations are going to be different. These patients are going to have edema. They may have respiratory failure because of fluid backing up in the lungs. They may have impaired hearing. They may have hemodilution. And the thing is that one thing that's common on both sides, you'll notice organ failure, organ dysfunction is common on both sides. When these two get to the extremes, then they can produce some similar results. Now this slide is just here to show you a couple of things. So what I want you to draw out of this slide is we'll come back to the portion that has the paracrine hormones and vasodilator substances. We'll talk about those concepts later. However, what I really want you to see is in this picture on the right that has the aortic arch and the cerebral arteries. You see the red dots there. Those are aortic arch and carotid body receptors or baroreceptors, and these are structures. You have receptors throughout your body in various capacities. You have proprioceptors, chemoreceptors, baroreceptors, stretch receptors, and we'll talk about some of these. These little red dots, they're not literally little red dots. These little red dots are the signalers for the sensation when you stand up too fast and your blood pressure drops. Your aortic arch recognizes it. The baroreceptors sense that change in pressure in the aortic arch. The baroreceptors in the carotid bodies also do it. That's why your head swims. They send a signal to the sympathetic nervous system that says increase cardiac output and help us not pass out. And that is where fluid gets recruited from that vascular space, like I was talking about before, to immediately increase cardiac output and you feel better. I wanted you to kind of have an idea where those structures are. I don't care that you know all of the anatomy there. I just want you to be familiar. But that anatomy is something you should know already. So I don't have any problems calling that out. Now, this last picture on the bottom is another component. We'll talk about this more when we get to regulation, and that is the renin-aldosterone-angiotensin system. This is imperative for you to be familiar with. This is just an introduction. I'm introducing it to you early, so you start wetting your whistle with this. But you're going to be very familiar with how renin, aldosterone, and angiotensin respond to maintain adequate fluid volume status, either by excreting or retaining fluid. So those are, I'm going to show you different pictures later, but that's a good one if you want to get familiar with it. So remember we were talking earlier about fluid distribution. My question to you is, where is blood pressure determined? Where in the body is the blood pressure determined by the body? Not measured by us, but determined by the body. You may think, well, it's the arm, because that's where we put the blood pressure cuff on, or it's in the lower arm, or it's in the heart. And the truth of the matter is, it's really in the lower, finer, smaller arterial bodies and structures of the human body. It's really determined, adjusted, I should say, in the arterioles. There's kind of a combination of effects here. Baroreceptors play a role, just as I mentioned, because we have baro and stretch receptors that also send signals. There's not necessarily one thing. There's a lot of things happening concurrently. So arterioles, baroreceptors in the heart and carotid bodies, like I just showed you, and then chemoreceptors. So chemoreceptors are receptors out at the periphery. And when I say periphery, I'm referring to anywhere there's a capillary bed. That's where nutrients are exchanged. When the cells in the capillary bed sense the exchange of nutrients, oxygen, carbon dioxide, these elemental nutrients. I'm not even thinking about food right now. I'm thinking about the elemental nutrients that keep us alive. Nitrogen, phosphorus, potassium, sodium, all these things we have to have, oxygen, carbon dioxide. The chemoreceptors respond and send signals to the arterioles that say, hey, we need to vasodilate, or we need to constrict because we need more of something, or we need to direct it somewhere else. We need to direct it to the muscles to get away from the bear. So there's really not one little spot. These different structures work concurrently to generate a blood pressure. What I do want you thinking is it's at the very fine capillary arterial level and cellular level this is happening, not in the vascular structure levels. So these things all signal the sympathetic nervous system and parasympathetic nervous system to adapt. And you know this if you've ever exercised or exerted yourself ever in your lifetime. When you're exerting, your body says, wow, we need more oxygen to keep this person from having a heart attack and dying. So your heart rate goes up and your body cardiac output goes up and your body responds. When you stop, that's the parasympathetic. And then when you stop, then the parasympathetic, that's the sympathetic nervous system. And then when you stop, the parasympathetic nervous system says, hey, that's all over. Let's calm everything down. So that is the way it